Good afternoon. Can you hear me? I think so, yeah. I can't hardly hear myself with all the noise. So, good afternoon and welcome to this session, symposium on ending TB transmission, stepping up TB infection control, the lessons learned and the opportunities in sight. My name is Max Meijs. I'm working with KNCV TB Foundation, based in The Hague, and also working for the Challenge TB project that has been funded by USAID in many countries, 22 countries if I'm still keeping up with the counting of the countries. So for this afternoon we have my co-chair here next to me. Let me quickly introduce him. His name is Ernesto Jaramillo from WHO Global TB Program. So we have 4 presenters on our list. Miraculously, we had 5 being uploaded there, but I think unless the 5th person who has come into that can raise the hand now, we'll see what we can do. But I think we have 4 presenters on our list, and we'll have a presentation from Namibia by Dr. Farai Mafunga. We have a presentation from Colleen Scott. We have a presentation from Carrie Tudor, and we have a presentation from Ed Nardell. And I've seen all 4 being in the room, so we can definitely move on. I think the important thing was, and I'm reading from the program, but it is good to have that all in your mind when we are listening to these presentations, is that ending TB transmission is the essence of the new WHO NTB strategy. We feel the quick detection of source of transmission and immediately enrollment on effective treatment is among the most powerful approaches to end the TB epidemic. Infection TB control offers additional tools which can contribute to prevent transmission in a variety of settings. And this symposium will present the state of the art in TB infection control and the most recent advances in the field and the progress of selected countries in mounting effective and sustainable infection control policies. So that's the promise. Let's see the reality. Dr. Farai Mafunga, can I ask you kindly to start your presentation?
Good afternoon, ladies and gentlemen. As introduced, my name is Farai Mafunga. I'm the program manager for the Namibia TB and leprosy program. So I will be sharing quite a bit of what we have observed, when it comes to implementation of TB infection control. So I consider myself a scene setter for this session, in that I'll present what is happening, what we've observed on the ground, and then the colleagues after me hopefully will present in more detail some of the specifics and a bit of the science behind some of the discussions. So I like pictures, so I just put that up. It's essentially a health facility in Namibia. I like that picture. I will not say why now, but probably a bit later we'll come back to it. I would like to acknowledge my colleagues who have been part of the work that I'm presenting now, in particular the field work, not necessarily preparing the presentation. But I also would like to acknowledge the USAID, CDC, and the Global Fund for funding not my presentation, but the work that has gone on in Namibia regarding infection control. I do not think I have any significant conflict of interest when it comes to this particular subject. I kind of took it for granted that when you say Namibia, people kind of know where it is, but I think 2 days ago I realized it might not be a right assumption to make. So it is a country in Southern Africa, very close, sharing a border with South Africa. Many of you would know South Africa, but it's not in South Africa. It's actually next to South Africa. It's one of the largest countries in terms of surface area, but also has one of the lowest population densities in the world. So I'll look at that brief background in terms of TB in Namibia, the interventions that we have put in place regarding infection control, Broadly speaking, I think I have very limited time, so I will not go into detail. And then talk qualitatively about the progress to date and maybe some of the lessons learned and some areas where we probably need a bit more input on how to proceed. We are in fact, we are one of the 30 high TB burden countries. The estimated incidence, I think, for 2014 was about 5,620. It's slightly lower for 2015. We have notification rates of about 436 per 100,000. And about 40% of those patients are HIV infected. And 44% of the cases reported in 2015 were new smear positive. And I think it's important to highlight this point because that essentially means that in our facilities we have a lot of infectious patients who are coming in for care for various reasons. We also have a significant relative burden of drug-resistant TB. And in 2015, we reported 320 cases of rifampicin-resistant TB, of which about 190 were actually MDR TB and 3 XDR TB cases. And I think for infection control purposes, it's important to point out that TB patients are primarily managed as outpatients, but also to note that the HIV prevalence is quite high. The antenatal prevalence for 2014 was almost 17%. So with that background in mind, of course, infection control has become a pivotal component of our strategic planning as of the second strategic plan, which was 2010 to 2016-17. And within this, we've actually included development of TB-specific infection control guidelines. And we've pushed through our partners to also get national level coordination of infection control. So we have a national level coordinator, and we also have a resident architect who's assisting us within the program in terms of addressing environmental control measures. We've advocated the establishment of infection control committees and development of facility-level infection control plans. So I think for those who are infection control, this sounds pretty basic. But when it comes to implementation, it's something else. We've also conducted quite a lot of trainings, cascaded from national to district levels to facility levels. And we have a few indicators in our strategic plan. Some of them are process indicators, which look at the trainings that we've conducted, how many facilities have infection control plans. But also we've tried to monitor the incidence or occurrence of TB amongst health workers. The infection control assessments that we conducted, and this is one of the key activities that we had targeted for the strategic plan, is to actually assess all the hospitals as a start, and maybe move to lower facilities after that. And so we did that, and we conducted quite a number of renovations and facility modifications in an effort to address infection control through PEPFAR and Global Fund funding. And we also introduced N95 respirators, which is supported by a respirator fit testing program. So now I now go to the practicalities of it. So these are some of the facility, if I can call them upgrades, that we've managed to undertake. So we have in places put up sputum collection booths. But I think more importantly, we have also established outdoor waiting areas within our health facilities. These were not there before, okay? So it was essentially, you get there, if you're going to wait, you have to go inside and sit and wait for care. But again, if you remember that 44% of our TB patients are actually infectious, and that the HIV prevalence is quite high, it's, chances of infection are quite significant. I debated whether to put this picture or not, because it looked pretty ordinary, but what I was told was that the before picture a lot of these windows were actually not openable. Okay, so these were windows which were meant for lighting only, without really, the ventilation component being included. So part of the renovations or modifications that were conducted is to actually put up windows that could be opened in these buildings. So this is for health facilities. The other level of care that we have in Namibia is we have what we call community DOT points. And basically we usually use shipping containers where we establish points where patients can go and take their treatment within communities. But again, a lot of patients would get to this DOT point, get in, sit, wait for care. Okay, so some of them could potentially still be infectious. So we also managed to establish outdoor waiting areas in these areas. So in addition to that, in some of these points, and I unfortunately don't have a picture of that, we also put up some whirly beds in some of these facilities to try and facilitate ventilation as part of infection control. So I'll consider that don't get me wrong here, I would say that's the easy bit. Modifying infrastructure. Probably expensive, but easy, because once it's done, it's done. I'll go on to what probably is not very easy, and it comes back to the first strategy. The administrative control measures, the ones that we say are the cornerstone of TB infection control. And number one, when you get to facilities, these are really not visible. So you get to a facility, you see nice windows, nice outdoor waiting areas, but in terms of the actual practice of infection control, these are really not as visible as you'd want them to be, despite, I think, the significant investments that have gone into this. So again, when I'm discussing this, it's probably the areas that we now need, a bit of discussion in terms of how do we move, from the simple to the a bit more, let's say, complicated and hopefully sustainable. Secondly, what we have observed is that while infection control, we trained everybody across the country, implementation is completely different if you move from one facility to another. These are people who have attended the same trainings. So we believe that there's quite a lot of individual, driven implementation of infection control in facilities. The plans, usually they are there, but implementation varies for various reasons. And so this is, I think, one of the factors that we have observed. And I think of particular importance is that if you train people today on infection control and you follow up tomorrow, you find that they are doing pretty much probably 60% of what they were trained on. Okay, if you go a week later, it's probably 30%. If you go 2 weeks later, it's down to 20%. A month later, I'm not sure, So the half-life of some of these interventions in terms of actual implementation on the ground, we have observed that it's quite low. And this is not helped by the fact that there's quite significant staff rotation in these facilities. So being able to systematize infection control within health facilities, it's probably one of the key challenges that we are facing. So we know what needs to be done. People are trained, people start doing it, but quite often sustaining it is an issue. And when you get to a facility, the administrative control measures, that's where you get most of the excuses, in terms of why is this not happening? We are overstaffed, we're understaffed, patients don't want to listen to us, and you have, there's always an excuse to not implement administrative control measures. And this is from health workers, of course. Whether those excuses are real or not, it's a different story. So, what do we need? I think we have had a lot of research into the efficacy of N95 respirators, the efficacy of UVGI, and I think Ed will talk a bit more on that later during the day. But what we really need to try and find out, and probably this is going to come from psychologists, is new approaches to make sure that what we introduce is sustained as much as possible. The problem with TB is that there is no immediate benefit. People don't see the immediate benefit of implementing infection control. So it's long-term, it's quite distant from the person who's supposed to implement it. So we really need ways to maybe stick to push implementation, as well as a carrot to also encourage implementation. So coming back to some of the key lessons, and I'm not sure if this is, the right solution, but what we've observed is that implementation of TB infection control, it's not an intermittent initiative. It requires sustained efforts, whether these are advocacy, whether this is repeated reinforcements, whatever is going to be done, I think it needs to be sustained. And I think this is a message to everybody, both implementers and funders alike, that once you've invested into infection control, it's not a once-off investment. I think it needs to be an ongoing investment. This is across all levels, whether administrative, environmental, personal protection. And we observe that despite people knowing what the right thing to do is, the numerous bad infection control practices, they recur if you do not consistently supervise. Again, it comes back to investment in infection control as a long-term thing rather than as an intermittent or short-term thing. Probably the most challenging component to implement, and I have my colleagues here who have been part of that, is the implementation of TB screening amongst health workers. What we observe is that a lot of health workers who are diagnosed with TB, they actually go to the private sector for care, and you only get to hear about it either by accident or the few that report to you, through the normal reporting system. So we actually do not have reliable data on the number of TB. I'm told we shouldn't say cases. TB burden amongst health workers. But it's something that we're moving on. Again, it's something where we need methods to make sure that we encourage and maybe even legislate the screening of TB amongst health workers. And coming back to the issue of why it's difficult to implement in the short term is that the indicators that we really have that can be tracked on a short-term basis, these are really just process indicators. So they don't really indicate the benefit to whoever is implementing infection control as far as TB prevention is concerned. So at the moment, it's really difficult to demonstrate that, and so it's also difficult to convince people to continue or at least invest more into TB infection control. So I think, by and large, up to this point, that's been our experience. And just as an aside, I think a study that we conducted about 4 years ago in Namibia did show that there was a significant association between previous hospitalization and drug-resistant TB. And similarly, I think in northern Namibia right now, we have noticed an increasing, it's only the only region in the country where there's an increasing burden of TB in terms of notifications, but also significantly increasing burden of TB amongst health workers. So we do have an obligation when it comes to infection control in our facilities. So maybe what I would consider key messages, long-term measures for infection control should maybe go more into ministerial health facility standards and norms, and we've started to do that so that we don't have to modify facilities regularly for infection control. But this becomes a long-term investment at construction level. At the moment, we've realized that having a dedicated focal person and comprehensive guidelines, it remains crucial to sustained implementation of infection control. One of the, okay, I have 2 minutes. But one of the observations that even Max recommends that, you don't need a specific dedicated TB infection control person. They can integrate into existing infection control committees, and the same person can do that. But are we really integrating ourselves into something that's working? I think that's the question. There might be an existing infection control person, but there's nothing happening, and we're integrating ourselves into something that's not working. So maybe we need to reevaluate this and maybe take the lead rather than join a failing initiative. And I think we need implementation research to inform development of self-sustaining approaches to implementation of TB infection control. Thank you.
Questions to the end, no?
So thank you very much. And thank you also very much for staying within time. I was sitting here and I was impressed. I know Namibia very well. I know the program very well, I should say, from the beginning of the presentation. I mean, I can see what has happened there. But still, I was impressed because the way you present it and the way you show it, I mean, it has, we mentioned that among ourselves behind the table here, it has never been written down like this. And I think countries, we should have more of these country experiences, not so much just the project, but the country experiences. I can allow one or two questions for clarification, but then in the interest of time, we move on to the next, and we'll see if we have some time for discussion later. So I see two hands being raised. Yes. Marty first, yes. Do you need a microphone? There is a microphone there. We like you to talk in the microphone because it is being recorded.
Thank you. Thank you, Dr. Mavunga, for a really good and interesting presentation. I want to ask you about the uptake of respirator wear by the healthcare workers. Namibia is a very hot country, very hot. And I can imagine that it's really difficult for healthcare workers to wear the respirators, first of all, appropriately, and then for sufficient periods of time.
Okay, thank you. Yes, when okay, when we talk about the bad practices that we're talking about, in fact, that's one of the commonest ones where you. It's a challenge to get health workers to take up N95 respirators, specifically for the reason that you've given, but also just sometimes we don't know. You just find that somebody's even wearing a surgical mask and an N95, on top of that. That's even two masks, in there. So again, it comes back to the reinforcement. So I think the uptake in DRTB facilities, it seems to be much better than in other high-risk settings that we would consider. Let's say, for example, in radiology or radiography suites. But in DRTB treatment facilities, we seem to have much better uptake than in other high-risk settings.
Yeah, thank you, Ed.
Thank you. I really enjoyed the talk because I think it spoke to the sustainability and the real issues for an entire country. One of the great things about these meetings is that we get to hear these experiences and maybe respond to them. So I'm hoping we can talk after the meeting. My colleagues have heard me talk about this endlessly, about an approach that I first read about from Atul Gawande, which was how oral rehydration therapy got implemented in Bangladesh. And it was not by policy, and it was not by education. It was by recurrent visits and recurrent, what I would call accompaniment. And I think there's a role for a team of knowledgeable people, a nurse, a doctor, an engineer, who would go facility to facility on a regular, not once, but over and over again. Where are you on implementation? What has fallen off? What can we do to sustain it? And I think it would turn out to be cost effective to do that. And we should talk because we have some ideas about that.
Okay, thank you.
Thank you, Ed. So some of those who were thinking that infection control is about having proper infrastructure and an architect based in the hospital are going to think differently. And at the end of the day, the healthcare workers are the ones who have to ensure that things happen. So that's why it's quite timely then to have Dr. Colin Scott, who is working with CDC, has been in the Epidemic Intelligence Service for some time, and is now going to share with us the experience of looking at how training of healthcare workers can make or not a difference in a country like Tajikistan.
Great, thank you. So good afternoon. I wanted to start with, I don't have any conflicts of interest that I know of for this presentation, but feel free to ask any questions at the end. So a quick background on the Central Asia region and particularly some of the countries there where we conducted the evaluation. The Central Asian Republics, or CAR region, is composed of 5 independent countries that were once incorporated in the former Soviet Union. We've got Kazakhstan, Kyrgyzstan, Tajikistan, Turkmenistan, and Uzbekistan. The tuberculosis prevalence in 2014 in this region was just under 200 cases per 100,000. And Tajikistan, where this evaluation is centered, had the second highest TB prevalence in the region with 128 cases per 100,000. Now, after the breakup of the Soviet Union in the early 1990s, the political and social changes seen throughout that region demonstrated the vulnerable healthcare systems and particularly the potential spread of infectious diseases. Specifically, the CAR region has demonstrated that TB infection control inadequacies and vulnerability make the countries vulnerable to both drug-resistant and MDR TB. Project HOPE is working in Tajikistan and throughout the region. And in reviewing the TB situation going on in that region, Project HOPE identified that strengthening the capacity of TB infection control practices, both in Tajikistan and throughout the region, should be an operational goal of the organization. So to do this, Project HOPE partnered with the Ministry of Health in Tajikistan, USAID, Global Fund, and the US CDC to establish a TB infection control demonstration site and base for national training. Together, they created a 4-day TB infection control training course, which included training on TB infection prevention and control hierarchies, TB infection control planning, prioritization, advocacy, implementation, monitoring, and evaluation. Instructors were used to engage training participants through interactive lectures, group and individual work, discussions, and skill demonstration sessions. In an effort to assess the initial impact of the TB infection control trainings being conducted by the center, Project HOPE partnered with US CDC to conduct a cross-sectional post-training evaluation of the first year of training operations at the training center. This was to better understand both the impact and utility of the trainings provided at the healthcare facility level. During the first year of operation, a total of 89 healthcare workers were trained in TB infection control over the course of 6 different trainings. This included 1 training of trainers, 5 cascade trainings, and 1 CAR regional training. For the evaluation, each of the 89 training participants received introductory letters inviting their participation and describing the purpose and time frame of the evaluation. A standardized interview questionnaire was developed to collect participant demographics, knowledge retention data, and self-reported use of implementation of the TB infection control material gained from the training. Additionally, we asked open-ended questions inviting some final thoughts or comments from each of the participants, telling us what they thought about the training and how we could improve it for future training participants. The interviews were conducted in person or over the telephone according to participant availability by trained interview staff. And these interviews were conducted in either Tajik or Russian according to the participant preference and ability. A total of 84 training participants completed the evaluation interview, which gave us a 94% participation rate, which was really fantastic. People were very engaged and wanted to participate in the evaluation and share both their experiences of the training and what they'd done after receiving the training. Of the 5 training participants who did not complete the interview, the contact information was incorrect for 2 participants. 2 more refused to participate in the interview, and 1 had to terminate the interview early. This is a table showing some of the demographics of our training participants who participated in the evaluation. As you'll see here, it was pretty equal between men and women participating in the trainings, with more than half of the participants reporting that they worked at either a TB center in a clinical setting or at a public health center in an epidemiologic setting. And you'll also notice that for roughly 60% of the participants, this was their first training or exposure to TB infection control principles and practices. So as part of our evaluation, we did assess knowledge retention by using the same knowledge retention tool used during the training. There was a pretest. The same pretest was given as a post-test after the training, immediately after the training. We gave the exact same tool at the time of evaluation. And here you see that the average knowledge retention scores improved from pre-training, 38%, to 86% in post-training. That's an absolute improvement of 48 percentage points at post-test. And then looking at comparing the post-test scores to evaluation scores, you see there was a reduction from 86% to 51%. Please note that there was a gained retention from pre-test to evaluation, though there was a reduction after some time after the training, which was described by my colleague earlier. We asked participants to describe various TB infection control practices at their work facility, both before and after attending the TB infection control training. And these included practices such as TB infection control training being provided for all staff at the facility, TB infection control educational posters being present or hanging on walls in posters, form of posters for patient waiting areas, masks available for patients, and so on. This is a very busy slide, so let me walk you through it very quickly. There are 2 bars for each indicator. So here's the indicator. This is the after bar, and this is the before bar. So before is before the TB infection control training. After is after the TB infection control training. You'll notice that the blue portion of the bar is the no. So that practice was not in use prior to the training. And the orange indicates yes. So this was in practice before the training. So you'll see that we want the reduction in the blue bar at each after section. And you'll see that overall, for this selected group of practices, there was a pretty decent reduction seen after, but that there were still some participants reporting that no, they were not engaging in those practices after. I have one more slide with a few more practices. These are a little bit less change seen. Oops. Less change seen. So you'll see that the bars remained a little bit longer for the no. And these ones we're looking at practices such as the workplace having a fit testing program, fluid-resistant gowns or coats being available for staff, and workplace use of ultraviolet lights for TB infection control. So some of the more expensive or more resource extensive practices are seen to have less of a change over time. Now, finally, we asked several open-ended questions eliciting participant feedback for improving future trainings on TB infection control. And as you can see from this slide, participants most desired having additional trainings available to them, as well as specific follow-up and advanced skills training. So what most participants discussed during their interviews was that the training they received was good, they enjoyed it, they wanted to begin implementing it, but they felt like after they went back to their facilities, they needed some additional training, additional knowledge or support to continue building on what they'd learned. So overall, training participants reported some improvements in TB infection control practices at their work facilities after attending the training at the training facility. And participants reported some of these being discussions with leadership at their work facility and increasing the TB infection control administrative controls after the training. Participants also reported that they tried to share the TB infection control training skills and principles with their work colleagues, either through informal or formal presentations, and trying to get others at their facility to understand the importance of TB infection control. Participants did demonstrate a limited knowledge retention of TB infection control practices at the time of evaluation, and this may reflect that for 60% of the participants, this was their first exposure to TB infection control principles and practices. So they needed to have it reinforced for them so that they would remember those principles and practices over time. Again, something we saw in the presentation from Namibia as well. This reduction in knowledge retention scores may also reflect a lack of information utility. And what that means is that training participants were primarily care providers and epidemiologists. The knowledge questions most frequently missed by participants were those focusing on the technical concepts or the environmental and engineering interventions, which aren't routine work for those types of practitioners. So a clinical care professional is not going to be thinking about environmental controls. So there could be a slight rift between what we expected them to remember and what they actually use in their daily work life and what they are able to remember and implement at their health facility. So this leads us directly to some of our recommendations. So there are some potential opportunities for future training program improvements, including the creation of a TB infection control training specifically addressing facility leadership. This would increase TB infection control knowledge and awareness of facility staff with budgeting and programming responsibilities. This would allow for some of those more expensive or resource-heavy requiring interventions to be planned for and budgeted for over the long term by those with that type of responsibility at a health facility. We'd also recommend inviting staff from all departments to participate in TB infection control trainings. All facility staff, including maintenance, facility maintenance staff, as well as the clinical workers and then the administration, could benefit from learning about TB infection control, and the training content for each of those cadres should be specific to the job duties that they engage in and where they can be best served by TB infection control to protect themselves and their colleagues. Additionally, we could develop a module dedicated to TB infection control action planning, which is directly linked to evaluation of the training. This would identify specific goals and activities, timelines tailored to workplace-specific needs, and action points or individuals responsible for those activities, which can then be used for follow-up evaluation to see what was actually engaged in and completed by each individual when they went back to their health facility. It could help improve and make the rigor of evaluating TB training, TB infection control trainings stronger, and also give you more quantitative evidence of what changes are occurring in the facility based on the training. Now finally, we would recommend developing a TB infection control peer network for training participants to continue sharing their experiences, brainstorm activities, and problem solve together after completing the training. Participants reported a strong desire for additional training and support post-training. And one thing that we considered as we discussed this desire and this need, instead of just adding additional trainings, bringing them in and providing more standard training, we considered a peer network as a different platform which could provide continued training through peer experience and peer networking for, while also providing a support system for those individuals to share and engage from their work facility. So instead of coming in for didactic training, they would actually be engaging in problem solving together through this peer support network, which might help solidify some of the concepts or bring it back to them in a new and creative format. So one limitation of this early impact evaluation is that only one CAR regional training was conducted during the first year of the training operations, which means the vast majority of the training participants were from Tajikistan, which means the findings from this evaluation are more reflective of this country than the entire CAR region. And because of this, and because this is the first TB infection control training evaluation conducted throughout this region, we also recommend that a more rigorous evaluation be conducted after additional CAR trainings have also been completed. Another limitation is the possibility that participants provided socially acceptable answers rather than providing constructive critiques of the training because they were invited and sponsored by Project Hope and the Ministry of Health. So it would be good to go back in again and do some more rigorous evaluation with it, doing more observations and less self-report. And finally, this evaluation collected those self-reported changes of TB infection control practices, which can be subject to both recall and social desirability bias, but is a good starting point since there's very little literature or very little evidence shared out there about TB infection control training evaluations. So it's a good starting point so that we know how to begin doing these types of evaluations. And finally, I wanted to speak to the importance of evaluating TB infection control training programs. There are a lot of programs out there, and there's very little evaluation being conducted, which allows us to know whether or not we're actually reaching our targets and whether or not we're making an impact for those healthcare workers who most need the training. So just to reiterate, evaluating the TB infection control training programs really helps the trainers and the funders to understand and identify ways to improve future trainings by soliciting feedback directly from participants. And without soliciting that feedback, trainers don't know if their teaching techniques and material are relevant and useful. And finally, the trainings really are able to demonstrate the value and benefits of providing the training. And without those evaluations, we don't understand what's happening on the ground after we train someone. So it's a better understanding of what's occurring because of what we've trained people on. And additional indicators of training impact could include screening and diagnosis of TB control staff to make it a more quantitative and more rigorous evaluation as well. So some things we want to consider as we move forward with evaluating TB infection control trainings and improving the training that we're providing to our healthcare workers. I'd like to acknowledge everyone who contributed to both the training program itself and to the evaluation of the training center. Thank you.
Thank you, Colleen. Thank you, Colleen. In the interest of time, I would propose that we carry on with the next speaker and we put questions towards the end, hoping that there will be time left.
So then I have the pleasure to introduce Kari Tudor. Kari Tudor is with the International Council of Nurses and, as everybody can see, proud to be a nurse. So
if you're a nurse and you want one, come to the working or subsection meeting at 5:15 in room 14.
The other thing is that it is even a greater pleasure that I can introduce Kari as well as the new chairperson of the NTB Transmission Initiative that is working under the Stop TB Partnership. She's taken over this chairpersonship from me. So I'm very proud and very honored that she is here and presenting on a topic that she knows very well about and has even published about. So Kari, over to you.
Thank you, Max. Good afternoon, everyone. Okay, so I'm just going to talk a little bit about some occupational risk factors for TB among healthcare workers, and then what the policies, current policies and practices are and how we might improve those going forward. So I think most of us in this room know that TB in healthcare workers is an issue, or else we probably wouldn't be here. It's estimated that about half of healthcare workers worldwide have latent TB, and there was just a recent systematic review published, I think last month, looking just at high-burden countries, and they also, in a pooled analysis, found that 50% of healthcare workers in high-burden countries had latent TB infection. The annual risk of TB disease due to or suspected nosocomial exposure in hospitals and healthcare settings ranges from 25 to 5,000, and that's from the Menzies paper in 2007. Many studies have found that healthcare workers have a greater risk of active TB than the general population, and I'll show you some data from a study in South Africa. In addition, in South Africa and many other countries, and especially sub-Saharan Africa, healthcare workers also have a high burden of HIV, or prevalence of HIV. And in one study in South Africa, it's estimated that 16% of healthcare workers also are HIV positive, which again puts them at a much greater risk for developing TB in the workplace. Several studies, as I said, incidence of TB in healthcare workers, especially in public facilities. And these are both two separate studies from one province in South Africa, that it's either 1,000 per 100,000 or 2,300 per 100,000 population, which is about twice to 3 times what it is in the province. And one study in Durban and KwaZulu-Natal, South Africa, also found that those patients with MDR-TB who were admitted to the hospital, this was based on self-report of occupation, that there was a 5-fold increased risk of healthcare workers having drug-resistant TB than the general population. So thank you to Ernesto for pushing this into the 2016 new Global TB report. So we know that from the 2009 infection control guidelines from WHO that countries are supposed to be reporting their TB incidence in healthcare workers or TB surveillance in healthcare workers. But as you can see from this map that many countries are not yet doing that. Of course, we see that the United States is blank, but we know that that data is collected as well as Australia, where I know in Netherlands, as Max pointed out, where genotyping is done of all healthcare workers who are diagnosed with TB. So I'm just going to focus on South Africa, which you can see is in bright pink. How do I point this one? So we'll just do a focus on South Africa for a minute or two. So this was a study that I did in South Africa several years ago now. It's in 3 district hospitals, and I wanted to focus on district hospitals that had an MDR ward on the same grounds as the general hospital, just to see if there was a difference between or risk of TB or MDR-TB among those working in different areas of the hospital. So the sample size was about 1,313 across these 3 district hospitals in KwaZulu-Natal. It's circled in red. So I won't show all of the data based on time today, but you can, the citation is down at the bottom. So we looked at cases of TB over a 5-year period in these 3 hospitals through chart review of healthcare worker records in the occupational health clinics in those 3 hospitals. And as you can see, the red line is the incident rate ratio of TB in healthcare workers, and the blue line is the general population. During these 5 years in KwaZulu-Natal, or at least in 2010, the last year, the incidence in this province was over 1,000 per 100,000. It was the highest in South Africa and still remains, has the highest incidence of TB in South Africa. But you can still see, even where there's a high burden of circulating TB in the community, the rate in healthcare workers was still about twice as high. So this is a busy table, and I just want to focus on, we looked at where healthcare workers had worked if we're talking about risk factors for TB, and many people think that the place that we need to put the most emphasis is in the TB ward. And in the adjusted incident rate ratio, we did find that those that worked in a TB ward did still have a higher risk of developing TB than those healthcare workers who did not. But we also found increased in pediatric wards, outpatient departments, the stores and workshops. So we think the stores, there's no ventilation in the stores because they have to be climate controlled. So air conditioning, so if one of the staff had it, they may have been passing it to other staff. But they do also go around the hospital. But in the, in the MDR wards, didn't reach significance, but there was actually a decreased risk of developing MDR for those staff that worked in the MDR ward versus those who did not, which we assume that that's because infection control measures, while not perfect, were in place. Healthcare workers were more aware of what the risks were, so they were more careful. So it may say that infection control works in protecting staff. HIV status, not all of the records had HIV status recorded, but even with those that we knew were HIV positive, HIV positive, yes, 3 times higher incidence of TB in those with HIV. There was no difference between occupation. So we did a case control study of a subsample of that 1,300, and we had responses from 145 people. And the thing that I want to point out here, again, the majority of cases were clinical staff, which were nurses mostly, and a high percentage of them were reported that they were HIV positive. But HIV positive, there was a increased odds ratio of 6 in terms of odds of developing TB among those who were HIV positive. So from this, it was a very small sample, but HIV came out as the largest risk factor for TB in healthcare workers. In the unadjusted odds ratio, the number of wards that healthcare workers worked in was also a risk factor, because those of us who are nurses in the room know that this week I'm in maternity, next week I may be in the TB ward, the week after that I may be in pediatrics, or next month. So we move around quite a bit, and so that brings different exposures. In many hospitals in South Africa, Namibia, other countries I go to, the male general ward will have very good infection control. I walk 5 meters down the walkway to the female ward, and it's it's much worse. So each of these wards also will have different risks. So the other thing that we did was to look at what are the occupational health policies and infection control policies at a global level, and this is on the right, or what was in place in South Africa at the time. So at the international level, we have the International Labor Organization has their occupational health and safety laws, and an X means that those are on the left, what the recommendations are, and the X's mean that it's in these individual international guidelines. And then in South Africa, they have a very good occupational health and safety act through the Department of Labor, and there is occupational, TB is considered an occupational disease in South Africa for healthcare workers. The ILO only recognized TB as an occupational disease for healthcare workers in 2005. It was considered an occupational disease for miners and other occupational groups, but not healthcare workers until 2005. So in these hospitals, these 3 hospitals, 2 had a full-time occupational health nurse, but only one of those occupational health nurses had actually had postgraduate training in occupational health. The others were warm bodies that were placed there and said, oh, today you're the occupational health nurse. Go do that. All had a full-time infection control nurse, but again, most of them, you're warm-bodied, you want to be the infection control nurse. Okay, now you're the infection control nurse. So they had positions, but they were not full-time dedicated positions. At the time of this study, none of them had an occupational health and safety officer to follow up on cases of TB and to do the appropriate paperwork. So when we looked at how many of the healthcare workers had been screened for TB in the year before. All hospitals said that they did it, but you can see that only about 19% of staff actually had a documented record of having been screened for TB in 2010. But yeah, so three cases of TB were identified, 1 in each hospital during that same period from those screenings. But the number of cases reported across those 3 hospitals was much greater than what they were picking up on the active screening. It varied from hospital to hospital, and screening varied also if you worked in a general ward or other area of the hospital or in the MDR ward. Those working in MDR wards reported that they were screened or supposed to be screened more frequently, 1 to 2 times a year. None of the hospitals used a standardized reporting tool or they all did something different in terms of screening for TB. And again, there was no guideline available on how they should screen or how frequently. So when we also looked at HIV counseling and testing, since that came out as one of the main risk factors for TB in healthcare workers in this setting. So about 22% of staff decided that or accepted to be tested for HIV when offered through the occupational health clinic in the hospital. Very few staff actually reported their HIV status, but some did, and about 12% of the staff reported that they were, or had it recorded in their health chart that they were HIV positive. So not too far off the 16% from the survey in South Africa. All of the hospital, or 2 of the hospitals were offering IPT. I've done a subsequent study that needs to be written up still about looking at how healthcare workers accepted IPT, HIV-positive healthcare workers accepted IPT through occupational health. They all said that they would reassign HIV-positive staff to lower risk areas, but many of the occupational health nurses didn't feel that there was a low risk area in the hospital that would be safe. And again, it's up to the healthcare worker to disclose their HIV status and ask to be moved to a lower risk area. So in some instances, the occupational health nurses felt that their hands were tied and couldn't force someone to do that. So some of the barriers to implementing the occupational health guidelines across these sites was that there was no health and safety officer, not adequate training for the job, so just being dumped into a position and not knowing what they should do, how they should do it. For some, it's only a part-time position, and they have, those of us who are nurses also know that we may have, I'm the occupational health nurse, but I'm in charge of the crisis center, and I'm working in the ward at the same time, so there's not a lot of time and emphasis to put on this job. Staff don't want to come for screening. Some of that, I think, is that they'll report as denial. They don't want to know if they have TB or not. They don't want other people to know, stigma, so there are many issues limiting staff coming to get their training. And again, as I just mentioned, that the HIV-positive staff have to be willing to ask to be moved to a lower risk area. Oops, did I miss one? Yeah. So some of the occupational health policies are in place, but they're not well implemented. I was hoping that Dr. Mvusi would be here today. The screening is happening, but as we saw, very few people actually go for the screening, and it's not finding that many active cases. More cases are coming in when they have symptoms and getting diagnosed passively. And as Farai said, in Namibia, many people, especially nurses and those that have insurance, do end up going to the private sector, but many of them will come back to get the treatment in the TB clinic because they know it's better and it's free. But we also see that there's some overlap with the roles between occupational health and infection control. And often I see that the more occupational health issues about identifying and surveillance of TB falls under infection control when really it's more of an occupational health issue. So some implications are that we need better occupational health policy specifically for healthcare workers, and this is why I was hoping Dr. Mvusi from South Africa would be here, because South Africa is, hopefully by the end of the year, they're going to have specific National Department of Health guidelines for occupational health of healthcare workers related specifically to TB and HIV, which may be of benefit to neighboring countries in the region, but to a wider audience as well. And I think that in terms of IPC, we need to do a better job of, or infection control community needs to do a better job of engaging occupational health at all levels to increase and improve surveillance. Healthcare workers need to be trained for the job they're doing, whether it's infection control or occupational health or being a TB focal nurse. And currently, I know this is some of the things that South Africa is struggling with in their guidelines is what do we put for screening? Chest x-ray, skin test, sputum. How do we do this? Do we make it mandatory or voluntary? So we need to, I think, guess as a task of the global community is to look at evidence-based screening algorithms for healthcare workers for TB. So thank you very much.
Yes, thank you very much, Kari. I think we move on.
Yeah. So let me introduce Professor Ed Nardell. Ed is professor of Harvard Medical School and is a long-time researcher in TB transmission and infection control, doing most of his work and research in Peru and South Africa. And when we look to the previous presentation, this presentation from Colleen that nicely shows how it's a major challenge to introduce social norms, but at the same time the heavy burden on healthcare workers when infection control is neglected. then make us wonder, okay, what to do to introduce social norms? Is there any chance for having a shortcut, a gadget, that can help us to do some impact with less effort or with some more engineering approach? So that is the topic of Ed. He wants to share with us what are the opportunities we have with UVGI. Thank you.
Thank you, Ernesto, and thank all of you for being here. It's a great opportunity to tell you about some advances that have actually occurred in this technology, which has been sort of in the shadows, I would say, for a very long time. And I'll list in detail some of the obstacles and why I think we are making some progress. First of all, I don't have any conflicts. Most of my work on infection control is funded by NIH and NIOSH and Fogarty, and I don't consider those a conflict. So we've already made the case, I think, that hospitals are dangerous places for healthcare workers and for patients alike. And of course, this kind of scenario of a very crowded corridor is not uncommon in many of the places where you work. We actually reported from Tomsk, Siberia, some time ago, that we were looking for what were the factors that accounted for MDR-TB in Tomsk. And I actually thought it was kind of a silly study because we all knew that it was non-adherence and poor programs and treatment decisions that on the part of healthcare workers that are providers that resulted in drug resistance. It turned out to be in Tomsk that if you were admitted to the hospital with drug-susceptible TB, instead of being treated outside the hospital, and you were adherent, you had a 6 times greater risk of developing MDR-TB than if you were not admitted. So this spoke enormously to transmission of MDR-TB and reinfection in the hospital. And for anyone who's visited, actually, hospital anywhere would treat MDR-TB or drug-susceptible TB, the scenario was a room with maybe 6 beds, new patients being admitted, and at that time, you would wait until patients were not responding before you would think about drug resistance, and then you'd get if you could, you'd get a test for second line for drug susceptibility and find out only months later that, in fact, this patient had MDR-TB, and other patients have been coming into that room and spending time for a very long time without any meaningful infection control. And of course, the most meaningful infection control is treatment. So a real problem, not surprising. And of course, the world's attention was really paid to, came to, to the problem of transmission, but the XDR transmission in KZN at the Church of Scotland Hospital. But it's certainly not the only place. So, you know, we have at WHO policy and in general, we've extolled the virtues of natural ventilation. And indeed, we would be in big trouble if we didn't have that resource. And we've seen an example, and I'll show you more, of natural ventilation at its best. Waiting rooms outside. Cold climates, however, we've got a problem. And increasingly, in warm climates, split system air conditioning is being installed. To heat or to cool, you've got to close the windows. So we suddenly have a condition where everyone's comfortable, but things are much more dangerous than they used to be. So, and once you start trying to ventilate buildings with natural ventilation, moving the air in and out of buildings, you have a much bigger challenge than you do with an outside waiting room. It depends on the direction of wind, the velocity of wind, whether the windows are open, and many, many factors. So although it is, in theory, sustainable, it really isn't always an effective way to achieve this. So we're using the term GUV instead of UVGI, which I'll tell you why in a moment, so for germicidal ultraviolet. And it could be the ideal complement or alternative to natural ventilation in many settings. And the problem is that it has not been easy to roll out, and it has not been accepted necessarily, and the sustainability question is huge. It also has limitations, and those are many of them, and we're going to talk about these limitations. So at Harvard, every summer we bring a group. Paul Jensen's in the back of the room, and he's in this picture somewhere in there. I can't see from here. But we do a course for engineers and architects. The architect from Namibia, I think you're probably referring to, has taken the course. And these are some of the buildings that have resulted from that course by architects. This is in Karachi, MDR clinic at the Indus Hospital. And you see a nice outdoor waiting area, and patients are brought in. Perfect. Now we have a hospital designed for airborne, for natural ventilation in Rwanda. Also pretty good. Hard to close, these windows don't close, etc. But not every building is like that. And not every condition is a hilltop in Rwanda. So you need alternatives to that. And so what we're talking about is fixtures that look something like this, usually in the upper part of the room, with these louvers that are designed in most cases for lower ceilings. If we had ceilings like this, we wouldn't need those louvered fixtures. We could get away with more simpler fixtures, open fixtures. We're not talking about room air cleaners that may have UV lamps in them. This is a motor that moves air. Now, when I converted this slide, it looks like this didn't become easy to read. I apologize. But what it says here is that whether this is a HEPA filter, a UV, a plasma field, an electrostatic precipitator, or an atom bomb in there, you can kill the bugs in the box. What you can't do is move very much air through that box relative to the volume of the room. So you will be approached by salespeople who will say, this is the latest and greatest box. And if you buy this, you'll take care of infection control. In fact, with extremely few exceptions, where you have a tiny room that you want to disinfect and the ceiling's too low for germicidal UV, and you want to put in an air cleaner, you can probably do that if you pay attention to the details, but very, very few exceptions. Now here's an example. Well, so what we're talking about in terms of upper room germicidal, and the reason it works so much better than air cleaners is that we use the entire upper room as an air disinfection chamber, if you will. And then we just have to move the air up and down, and that's not difficult to do with low velocity paddle fans. So we get an enormous amount of air disinfection within the room. And it's perfectly safe, as we'll tell you about, although my colleague Paul will say it's inherently dangerous, but we make it safe. And that's a sort of a half full, half empty approach, but you'll see. So warm air rises, but with a good ceiling fan, any ceiling fan, you get a good deal of air mixing. So, and in terms of cost effectiveness, and this is a study that Paul Jensen and Grigory Volchenkov, our colleague from Vladimir, did a number of years ago, actually he said 10 years ago, and compared in a room aerosolized organisms to which they did quantitative air sampling. They used upper room germicidal UV, a locally produced inexpensive fixture you see here, and they had a ventilation system to compare, and they had 3 different air cleaners, including a ridiculously expensive one that was put up in the space capsule. So, I mean, they used everything. And this one literally had an atomic bomb in it to kill the organisms, but it didn't move that much air. So you'll see that the cost per equivalent air change, if you compare them, there is nothing cheaper to rendering air non-infectious than upper room germicidal UV. And if you do it simply in terms of relative risk compared to ventilation, which is 1, it's almost 10 times, 9.4 times more cost effective to disinfect air with this technology than with any other alternatives. So I think it's time for a paradigm shift. We've sort of presented upper room germicidal UV as, something unusual, something maybe unsustainable, dangerous, but it is actually, if natural ventilation isn't reliable And if mechanical ventilation isn't available and is very expensive and air cleaners don't work, there really isn't an alternative to upper room germicidal UV for congregate settings if you want to achieve high levels of air disinfection. There is no good alternative. And if somebody comes up with one, but we've been waiting a long time. So here's an example of that room air cleaner problem. And this was from a meeting, Toby Van Reenen is here from the South Africa, and in a meeting we had, as usual, there was a guy selling an air cleaner, and we pressed him, and he found some literature on his device, and it produced 23.3 liters per second, so-called clean air delivery rate. It's 60 CFM, cubic feet per minute, translates to 28.3 liters per second. We make a room 4 meters by 4 meters by 3 meters high. That comes out to a whopping 2.1 air changes, assuming that air is perfectly mixed and it's cleaning all that air. It's not meaningless. If you have no ventilation, that would be okay, but that's not great ventilation. We're talking about 6, 12 air changes per hour, and as you'll see, we can get much more than that with upper room air disinfection. So do not believe the salespeople who come to you with the latest device, whether it has got filters, UV, or any other air cleaner. You will kill everything in the box, but you can't move enough air. So where should it be used? And here's another sort of a heresy. Not necessarily on the TB ward. You heard Carrie Tudor tell you that on the MDR wards, there was very little tuberculosis transmission. It may be because of better air infection. It may be that everybody was on effective therapy, and there's not that much, well, there is in quasi-ed, but hopefully they've been diagnosing the XDR TB. And you know, on general medical wards, it's on suspected TB cases. So if we treat TB cases, and people on the TB wards are not that infectious. So it's the unsuspected case, and that's where emergency room, outpatient waiting rooms, corridors, jails, shelters, art centers, those are the places where unsuspected cases occur and where you need air disinfection. Other places, if you can diagnose and treat, that's much better. So what have been the barriers? And I know this looks like a long list of barriers, and it is, but the good news is that most of them we actually have addressed or are being addressed. Acceptance. Convincing of efficacy. I'll show you, we have lots of evidence of efficacy. Fear. So that's why we have taken the I out of UVGI, because people are afraid of irradiation. And it's not ionizing radiation, it's, you know, well, I think I have a slide on risk in here, but when you go outside, even in Liverpool, but especially in South Africa, you get much more dangerous UV from sunlight than is generated in a room with germicidal UV. The threshold limit value is actually quite low, and the risks outside are much, much, much greater than from germicidal UV. So, but we need to address the fear factor, and so a lot of education is needed here. Dosing guidelines, we now have them. They're practical, they're evidence-based, and in fact, in South Africa, they're about to release a national GUV guideline, a UVGI guideline, which I think you'll be able to access as an example of a thought-through guideline and how to use this technology. We still have to get expertise more widely dispersed to plan, install, and commission. So at a meeting we recently had in Pretoria, somebody kept asking, okay, if I want to do this today, what do I do? Number one is you have to find a consultant who can help you with this. And then they will know which companies make good UV, and you'll see those UV fixtures have to have been measured for how much UV comes out of them. For years and years, we didn't do that. We just dosed by how much electricity went into them, which makes no sense. We have to know how much UV comes out, as you'll see. And so you need a consultant, and obviously you need some money, and then you need a maintenance program. And that's a huge challenge that we are addressing, but you have to think of, don't buy these and expect they're going to work, because they're not, unless you have somebody. Ideally, you would contract with a company that would do this, and we're trying to build that capacity to address the maintenance issue from a number of angles. You have to have electricity, that is a given, and you have to have air mixing, maintenance, and you have to have some money, and then sustainability means that this industry has to become a profitable business, including maintenance. Right now, you find articles by our group and other people talking about how well it works, and there are a number of manufacturers who make these things, but it's not enough of a business that, you know, if you want a biological safety cabinet, you call the company, they bring it in, they install it, and they'll maintain it. We need to get at that level of that kind of expertise, and we're working on it. It's almost there. So I've really gone over the advances that we've said here, and we'll go through them in a little bit of detail. This is our research facility in Mpumalanga, South Africa. It's part of an MDR-TB hospital. There are 3 rooms here, each 2 beds to a room, as you see. All of the air is extracted from these patients who have MDR-TB or XDR-TB, and the air goes to one of 2 or both exposure chambers, which contain up to 180 guinea pigs on each side. And you see here a guinea pig having its skin test read very carefully. So guinea pigs are exquisitely sensitive to TB, much more so than humans are normally, and will tell us how much TB is in the air. And in 2016, it's the only way we have to quantify TB infection of infectious air. You can culture it, not out of ambient air. You can culture the air if you put enough organisms in the air in the first place, like Gregory and Paul did in a study, but you can't culture TB out of the air that's naturally produced. Guinea pigs will sample it for you and tell you how much infection there is. So this is the study we did. We put these fixtures on the wall. We take the air out of the room through the ventilation duct to the guinea pigs, and we had ordinary, inexpensive paddle fans. We sent the air on odd days. Every other day, the UV was on in the rooms, and the air went to these guinea pigs, and on even days, the air went to these guinea pigs. So that at the end of 3 or 4 months, as you'll see, these guinea pigs only breathed the air when the UV was on, and these guinea pigs only breathe the air when the UV is off. So we want to know how effective this or any other intervention is. We simply do this on this alternative day. And why do we do that? Because we want to make sure that patients are equally infectious every day. And if we did it this week and the next week, maybe something would change. But this gives us a controlled experiment. And here are the results. After, in fact, 4 months and 3 months, we had 57 infections of guinea pigs in the control room and only 15 in the intervention room. So this was a hazard ratio of 5 almost, of about an 80% effectiveness, the equivalent of adding to the existing 6 air changes a total of 24 equivalent air changes. Remember, 2.4 air changes from the air cleaner. We're talking 24. That's a lot of air changes, maybe more than we need. We're wondering whether the dose that we used here was higher than necessary, but it was what we used, and this has been published. Matsi Mfuleli was our first author from South Africa, a number of people here, including Marty, who's in the audience. These are some of the fixtures we use, and there was an editorial that said, this is time to scale this up. We know how to use this technology. We have still the barriers of dealing with maintenance, but safety. So the healthcare worker or the patients are exposed to a little bit of UV that bounces off ceilings, etc. We know what the threshold limit value is. You'll see in the next slide that we have monitored patients, we've monitored nurses and others, office workers, etc., with this in use. And because you're moving around, the eye is the most sensitive organ. The skin is really not very sensitive because it gets absorbed. This UV doesn't penetrate skin. It does irritate the eye like sunlight can, but it is, when you monitor people, and this paper, published paper, human exposure, the highest rate of exposure was a patient who got 1/3 of the threshold limit value. Not a half or even over, 1/3. And this is with fixtures that were actually fairly poorly designed, I have to say. So this was a worst case scenario, a hospital in Boston that had UV up, and we monitored people continuously. You move around, you don't look at you're not staring at the UV, and the only accidents we see where people do get irritation and no permanent damage is from climbing up on a ladder without turning off the fixture, cleaning it, that kind of thing. There are safety precautions that are needed. The fixtures have to be properly designed, but these are, quotes, properly designed fixtures. You see they produce a fairly narrow beam in the upper room. Unfortunately, these louvers also gobble up almost all of the UV. So they're not the most efficient ways to use germicidal UV, as you'll see. Now here is a fixture in the hospital we work in South Africa, put in a low ceiling, excellent design for a high ceiling, poor design for a low ceiling because of these widely spaced louvers. Very efficient, killing bugs left and right, but people were complaining about eye irritation. So we need well-designed fixtures as well. So dosing guidelines, all I can say is we used to depend on a very early experiment by Richard Riley, which his office was 200 square feet. This shows the effect of one 17-watt fixture on aerosolized BCG in that room. It came out to be 17 watts, produced about equivalent of 10 air changes. And if we had 30 watts, we figured we would have a 2 minutes. We would have a good effect. But we didn't know how much UV that fixture was putting out. So it was really, we were talking about 17 watts of electricity going in, and that made no sense. NIOSH came up with some guidelines in 2009, and they also had sort of unworkable guidelines. An amount of UV in the upper room, which you can't predict in advance, or again, 6 watts of input, not output. What we showed in the study I showed you, and by the way, Rod Escom in Peru did a similar study. He didn't have as much information on the output of the fixtures, so we're not using that data, but the result was very similar to ours. He got 72% protection, we got 80% protection, very similar. So anyway, we're using, and you don't need to remember this, 15 to 20 milliwatts of total fixture output per cubic volume. So the important point is here, you know the volume of your room, 10 meters, 5 meters, 3 meters, that's 150 meters. We're using 17 milliwatts per cubic meter. We need 2.5 watts. A fixture puts out 0.5. We've had it measured, and we need 5 fixtures. End of story. Now, I'm not going to have time to go into great detail into dosing, but for example, we would like to put the fixtures on a wall that is longer rather than one that is shorter because we get more use out of that UV. And there are design tools available that can be more sophisticated for an architect to use. But basically, and we now know that all fixtures are not alike. These fixtures with a better parabolic reflector and more carefully designed louvers are 10 times more efficient than those fixtures. So we need to know what comes out of the fixtures, and your consultant will know how much comes out of these fixtures as we get more and more of them measured. And that's how we measure them. We won't go over that. Finally, LED UV is on the horizon. We're testing fixtures that will allow battery power backup, solar power, and probably more creative use of designs of spreading it. And the wavelength of germicidal UV out of these LED fixtures is a little closer to the peak germicidal wavelength and still far away from what causes skin irritation and photokeratitis in sunlight. This is the first prototype of an LED fixture. It's just sitting on a bench, but we're going to be testing these in our test chamber in the coming months. And this is our postdoc that's going to do that, and that is that.
Thank you very
under
much.
time.
Oh, okay.
Thank you.
Thank you very much, Ed. So there is some hope, right?
Yes.
Actually, it's a reality. It's a matter of moving forward to implementation and to more systematically take advantage of this. So floor is open for questions. I would like to invite you to be concrete, short, crisp, to the point, also for quick and crisp answer from the speakers. Yes, please.
Hi, my name is Elena. I'm from TB Proof NGO for, amongst other things, occupational TB in South Africa. So mine is more sort of comment to Kerry, there's Kerry, about the National Occupational Health Policy. So we were civil society partners in providing feedback on the policy. And some of the very difficult questions that had to be answered was firstly, is there high risk and low risk within hospitals? Should we put that in a policy at all, or are all areas high risk? Secondly, the issue of confidentiality. So if a healthcare worker is diagnosed with, for example, MDR TB, should we break confidentiality and sort of compel them to report it to their workplace so that we can do contact tracing, and sort of if they work in a pediatric ward, for example, that the children can be screened, or do we respect their confidentiality above all? And then thirdly, another very hot topic was who should be included in occupational health policy, because traditionally we think about nurses, we think about doctors, but we forget about, for example, the cleaning staff, the kitchen staff that take the food to the patients, the medical students, the nursing students that also work in our facilities that often just fall through the cracks. So maybe your thoughts on some of those controversial topics.
Just keep it first. 3 questions.
Well, okay. Yeah, go ahead. But again, short question, short answer, because we are really running out of time. Sorry about that.
We can discuss later.
Yeah.
Personally, my belief is that we need to, and Ed has said, is that it's not just the patients in the TB ward and MDR wards are diagnosed on treatment. What we need to think of healthcare workers throughout the facilities, primary healthcare centers, OPD, everywhere, because those are the unsuspected.